Let's now move on and let's talk about valvular heart disease. Last year, there's been several important publications and presentations occurred in the treatment of aortic and mitral valves. So let's start with the aortic valve, George. I'm going to give you a question. You know, what do you do for a patient who has severe aortic stenosis that you see in the office and is totally asymptomatic?
Well, the classic teachings that had gone on for years was no symptoms, no surgery. And that was sort of the approach to it. And I think it was all based on the mortality for surgery, which was high at that point. This is kind of the traditional thing. And that many of these patients did as well if you just left them alone. But we've now entered a time of different therapy for the aortic valve, better surgery, better non-surgical approaches. And we were able to pay much more attention to the long-term damage that occurs to the heart from aortic stenosis. And that's, I'm sure, a driver more than just mortality. We want these patients to be better. One of the ways people have tried to approach this is with stressing people with severe aortic stenosis to see what their response was. And I think
it's very underutilized, though,
right.
Putting people on treadmill.
But I do think
that's
that's a useful thing to really see what the impact of that disease is. I always remember a young guy I saw with aortic stenosis. He was playing baseball, and there was this argument about whether we should replace his valve or not. He was in his 30s. He was doing this for fun, and he had over 100 millimeter gradient across the aortic valve. We replaced his valve, and I remember him saying to me, you know, I'm turning my doubles into triples now, because he didn't understand how limited he really was. And I think we've missed that along the way.
So there is some minimization of symptoms, and sometimes we misclassify the patients. But there is some guidance now in the literature. A trial that was presented called Recovery, that evaluated patients with severe asymptomatic aortic stenosis, mean gradient of more than 50, aortic valve area of less than 0.75. They were randomized to either open surgery versus observation. 272 patients, pretty good number, and there was an 8-year follow-up. And the primary outcome of the recovery trial was operative or cardiovascular mortality at 4 years. And that was presented. There was 1% for surgical AVR versus 15% for observation. So clearly, I think that we need to pay more attention about looking at how we classify these patients, perhaps increase our use of exercise testing to elicit symptoms. And my threshold for offering them aortic valve replacement is getting lower and lower for patients with a true severe AS.
Yeah, I think there are two caveats here I'd like to add, though. We really need to have really good evaluation of the patient. Some of the echo quality is variable, and I think we really need to pay attention to good quality echoes to make these decisions on, because most of them are now made non-invasively. And the other is we have to look at the patient risk in deciding. The younger the patient, I think the more we're going to pull the string earlier and replace their valve.
Yeah, so just to mention something that I think is interesting, you know, in our practice now, we are using more and more of calcium Agatston scoring of the aortic valve to determine the severity, especially for patients, those who have low flow, low gradient AS, because it becomes very challenging sometimes to find out, you know, these patients could be very sick, you know, they may not be suitable for the vitamin stress echo, a very difficult decision making in these patients, and a calcium scoring can be helpful as well if there is a question whether the aortic stenosis severity is significant or not.
Well, I think that supports my point. I just think we have to have really good quality data to make these decisions.
Especially in a younger patient that you're going to subject them to. So, you know, TAVR now obviously approved in the low-risk patients. Would you offer a TAVR?
Yes,
to somebody who is a low-risk young patient who has severe AS?
I mean, I think the young patient is the most difficult. We really need to understand what the longevity of the valves are, of the TAVR valves. I think that's the one piece that we're not totally sure about. And I think it's a fair discussion with a patient. It's possible to do valve and valve and so forth, but the valves will be better. But I think as part of the discussion is a little bit of the unknown about the long term of the valve.
Yeah. The other thing that, I wanted to discuss with you was, when you talk to these patients with severe AS, about your recommendation about mechanical versus bioprosthetic valve, at least in recent years, the majority of the patients, when we had discussion with them about surgical valve replacement, they almost always pick bioprosthetic valve. So when it comes to a younger patient, if you put a bioprosthetic valve in, you may not now have the very, very long-term advantage that you might have with the mechanical valve, but the patient's going to end up on chronic anticoagulation for life. And that's is a problem.
That's a very difficult decision. And somebody who's in their 30s or something like that, it's unusual, but the issue of the valves calcifying rapidly and so forth is one that I think becomes a different challenge. And unfortunately, once they have the mechanical valve, their next procedure is going to be another surgery.
So now you have a patient who has moderate to severe AS, and you see them in the office, and they may complain of, say, I have dyspnea on exertion, the valve area is really borderline, the gradient is borderline. How do you follow these patients, and is there any guidance in the literature now?
Well, the guidance I think is very helpful to get serial stress testing on them if you possibly can, to see if where they are and if they start to decline, because sometimes that's not easy to ascertain in people who are relatively sedentary. I think that's an important issue, and they have to have regular follow-up in terms of echocardiographic evaluation and so forth, because I don't think you can totally depend on symptoms, particularly now when we're moving away from symptoms as the only criteria for deciding.
Right. There was a trial called SEAS that was presented last year, which looked at the pro-BNP levels to monitor mild to moderate AS. Now, I have not been doing that. Can you tell us a little bit about SEAS data?
Well, they looked at patients with having a couple of biomarkers and pro-BNP and a couple of others. The biomarkers are hot right now, and I think they're going to tell us a lot of things. I'm not sure we can totally make decisions on them now, but I think they're worth getting and following them.
Right. So if there's a doubt about whether they are having true heart failure symptoms, pro-BNP could be helpful. Yeah, and then maybe another pro-BNP 6 months later to see if it goes up, that might give you a suggestion that they have an early left ventricular failure. This year at ACC, there were also two low-risk trials which were presented, Partner 3 and Evolute. In Partner 3, the primary outcome was all-cause mortality, stroke, and cardiac rehospitalization. And 1-year data was presented, and it was 8.5% in TAVR group compared to 15.1% in SAVR groups. And Evolute low-risk study, similar findings were seen as well. So what were the other differences? So both trials showed less perivalvular leaks with SAVR than TAVR. The length of stay was low in the TAVR group in comparison to surgical group, which might have some economic implications. A pacemaker rate in low-risk Evolute trial was almost 17% at 30 days, and it was not 0, but 6% in SAVR group. So, it looks like a great data for low-risk patient with TAVR. Are you offering TAVR to your low-risk patients now?
Well, I think we're still making individual decisions on patients based on their circumstances. I think that most of the patients do want it.
Yeah. So, patients demand it. That's really, the number one thing that we see. I see several patients that come to our office and said, I will not have an open chest surgery for aortic valve. Give me a TAVR valve, because there's been so much information available now in the new world that they can easily get this information online. So we've been clearly offering more and more TAVR procedures to an appropriate low-risk patients. Probably, perhaps not in a very, very young patient, where we might, think twice about it, given, the potential not having a very long-term data available on this TAVR valve. Okay, so that's all about aortic valve. Let's now turn our attention to use of aspirin. And 2019 has been a year that will be remembered for aspirin use, as many important trials came out looking at aspirin use in our practice. So let's first talk about the Augustus trial, which I think is an extremely important study, which looked at, addressed the patients with atrial fibrillation who received PCI and DES and now needs an anticoagulant therapy as well as DAPT. So the questions are, should they be on NOAC or warfarin? And second question would be, can aspirin be omitted? So Augustus answered these questions. Augustus enrolled almost 4,600 patients with atrial fibrillation who had acute coronary syndrome or underwent PCI procedure with drug-eluting stent. The trial had 2x2 factorial design. The patients with atrial fibrillation undergoing PCI were randomized 1-to-1 to either apixaban or warfarin or either 81 milligrams of aspirin or placebo. The primary safety outcome was bleeding, which was lower in the apixaban arm than in warfarin. It was 10.5% for apixaban versus almost 15% for warfarin, a highly statistically significant difference. At the same time, aspirin group also had higher bleeding, 16% versus 9% in the placebo, a very highly statistically difference as well. Now, when we looked at the ischemic endpoints, such as stent thrombosis between these groups, there was no statistical significant difference between patients, those who were on triple versus dual therapies. So overall risk of stent thrombosis in the study was 1.6% within the first 60 months. However, majority of these events occurred in the first 30 days. Among patients with atrial fibrillation with recent acute coronary syndrome or PCI, adding apixaban to P2Y12 inhibitor results in lower bleeding compared to vitamin K antagonist or warfarin, and with lower rate of death or revascularization. Regardless of apixaban or VKA use in both arms, aspirin resulted in greater bleeding without any benefit to ischemic outcomes. So the take-home message here was that apixaban causes less bleeding than warfarin when it combined with clopidogrel in the setting of PCI. Aspirin increases bleeding when used as a part of a triple therapy in patients with atrial fibrillation who had undergone PCI. So George, what are your thoughts? Are you going to eliminate aspirin in patients with AFib who you just implanted a DES, or if they had an ACS, got a PCI, or a medical therapy?
Well, the really tricky question, I think, is what's the first 30 days?
Right.
At the time of the procedure and 30 days. With the greater risk of stent thrombosis in that time frame, I think a lot of people are going to be reluctant to just totally give up on aspirin at that point.
Right.
I think after 30 days, it's going to be really easy to go with apixaban and P2Y12.
Yeah. So numerically in the trial, in the first 30 days, for apixaban without aspirin, there was slightly higher stent thrombosis risk. Also for the coumadin, the same thing.
Right.
So it seems like that there may be some early benefit of aspirin. So some people are giving it for a week. In our practice, we are doing it for 30 days of aspirin, and then after 30 days, we'll discontinue the aspirin and continue patient on apixaban and clopidogrel. Now, it's important to remember that in Augustus, clopidogrel was the P2Y12 inhibitor which was used. But we're not going to forget about ticagrelor and prasugrel. So, George, since Plato and Triton TIMI 38 has been presented, we have really moved on from clopidogrel to ticagrelor and prasugrel in patients with ACS, and probably ticagrelor being the dominant player in U.S. So these are clearly more potent antiplatelet drugs, and they certainly have potential to cause more bleeding. Now, there was an important trial called Twilight that addressed the issue of ticagrelor monotherapy with aspirin omission. Can you talk to us a little bit about Twilight?
It was really looking at the question again of eliminating aspirin and seeing if you could get the same clinical efficacy without having the bleeding risk or the same level of bleeding risk. The study was designed to not just take low-risk patients, but to take patients who had to have high-risk clinical features such as old age, bleeding risk, so forth, and high-risk interventional characteristics or coronary characteristics that included in-STEMI, or they excluded STEMI, but included in-STEMI and some of the other findings that suggest complex coronary disease. And then they kept the patients on triple therapy for 1 month, and if they had had no bleeding event at 1 month, they were randomized then to just continue
Brilinta
versus
Brilinta and aspirin. Yeah.
And at the end of the day, it didn't make any difference in terms of
stent
cardiac
thrombosis, ischemic events.
Same events, and it was lower bleeding.
Right.
So it was a win, and it wasn't complicated by other, a lot of covariates that you'd think would do it. So I think this is helpful information in non-STEMI patients, at least, to think that one can reduce the use of antiplatelet agent early, and I think it's a product of better stenting and better stent devices.
Right.
And reduce the risk of bleeding.
The other important study that was also presented last year, which was done by Japanese colleagues, called STOP-DEP2. And they looked at patients who had almost 3,000 patients with PCI who had Zion stent, and they looked at 12 months of DAPT versus 1 month of DAPT followed by 12 months of the remainder of the clopidogrel monotherapy. The primary outcome in STOP-DEPT was death, MI, stent thrombosis, stroke, and bleeding at 1 year. And it was better, 2.4% in clopidogrel monotherapy group after the first month, versus 3.7% in the dual arm for almost the full 12 months. So clearly the 1 month DEPT strategy followed by clopidogrel monotherapy appears to be very good based on STOP-DEPT2 trial. Now, one group in the STOP-DEPT2 that did favor a 12-month of DAPT was patients with chronic kidney disease. So it seems like that after short duration of aspirin post-PCI, dropping aspirin appears safe and causes less bleeding. So any other thoughts on aspirin?
Well, there's the whole issue about whether we should all be taking an aspirin a day.
Right, primary prevention. So the guidelines did downgrade it.
They downgraded it because there have been a lot of studies that have failed to show the benefits. There are some caveats. There's at least one trial that suggested that body weight might influence that, and maybe we've gotten bigger, and so the effect of 81 milligrams of aspirin may be less. The other thing is that a lot of the trials don't look at chronic statin therapy and whether that's a factor that has diminished the effectiveness of aspirin. So I'm still a little hazy about a patient who's not on a statin, so forth and so on, has minor risk. Maybe they need a little consideration for aspirin sooner. On the other hand, I think it's very clear that for very low-risk patients, there's really no reason to have them on aspirin based on all the data because you're going to reduce the bleeding risk. Right. And on the other hand, people who, in terms of secondary prevention rather than primary, clearly the aspirin issue is, as we've talked about, complicated by the circumstances, but is not a non-starter. I think you need to consider it.
Right. No, I think that's great. Yeah. So, George, let's finally discuss a few additional trials, and then we will conclude our discussion by discussing mechanical circulatory support in cardiogenic shock. So the first of these additional important trials that we're going to talk briefly about, first one is COAPT, which was a mitral clip versus medical therapy in symptomatic heart failure patients with a functional +3 to +4 mitral regurgitation. The study results were very favorable for MitraClip. MitraClip reduced heart failure hospitalization and mortality compared to medical therapy alone at 2 years. All the quality of life measurements were better with MitraClip. There was also a cost effectiveness analysis that's been presented, which showed intermediate cost effectiveness for MitraClip. But this really will fundamentally change, how we treat functional MR, in these really sick people.
This is really important. I must say that, we see a lot of these people, and valve surgery was never ideal, and it was a big hit on people that were already stressed. They went to the surgical repair, but so many times we'd see somebody who was good for a month, and then you suddenly heard the murmur back. And so this is just a great situation to offer a real treatment to patients.
One thing that does bother me about the CMS decision on only allowing MitraClip in a centers which does at least 25 mitral valve surgeries, because I can tell you many centers I know where there are very accomplished imagers and echocardiographers and interventionalists who can very safely and very well do a MitraClip procedure. So I'm not sure why these two things were tied, and I hear now that it's going to get even more stringent. Do you have any thoughts about why a surgical volume was entered into a decision on who should have MitraClip?
I don't know. I know what everybody's concerns are, is that small centers that really don't have the expertise or the way to get out of trouble if they have a problem will start trying to do procedures that they're not really capable of covering all the complications, and no one wants that. That brings down the value of the procedure across the board.
Right.
On the other hand, you start limiting patient accessibility by geography, by a variety of things, and excludes operators that are very good operators that could do it. And these fights will continue to go on and are very difficult to
influence.
All right.
Yeah. We've been having this debate in our hospital about patients, those who come to the emergency room with cardiac arrest. And the knee-jerk response is call the cath lab. So now there is some guidance, and there was a very important data that was presented from COACT last year. So tell us about COACT.
But COACT is really a kind of an ongoing study. The original presentations and information was on the 3-month data. COACT is basically taking a patient who had cardiac arrest, is successfully resuscitated, has an EKG that does not show an acute myocardial infarction.
Right.
If you look at the data, a high percentage of these patients have coronary disease. And so there's been this thought that maybe if you took them to the cath lab, reopened whatever arteries needed to be opened, that they would do better. The COACT trial randomized patients, and they first looked at the first 3 months and didn't show a difference with revascularization for this population. And now they presented quite recently the 1-year results, and it didn't show a better outcome for the patients who got acutely revascularized in the absence
of ST elevation.
ST elevation.
Yeah, I think this is very important because we have changed now the protocol in our institution as well, that if they do come in arrested, but they don't have ST elevations, we should not rush them to the cath lab. We need to stabilize them.
Now, stay tuned. There are several other studies looking at this, so there will be more forthcoming data. But at the moment, I don't think
it might help us more in further decision making.
Yeah. But right now, I think you're right.
Yeah. Okay. So let's move on to in the same area of cardiac support issues. Let's talk about mechanical circulatory support. So there's 2 recent presentations at AHA, which has created quite a stir. Looking at outcome of mechanical circulatory support in acute myocardial infarction and cardiogenic shock undergoing PCI. The first study which was presented was a study which was done in collaboration of Yale and Mayo Clinic and was supported by a grant from FDA. It looked at about 28,000 AMI cardiogenic shock patients in NCDR CATH PCI registry as well as chest pain MI registry. Out of 28,000, almost 8,500 of patients received balloon pump. About 1,800 received Impella, and 1,800 received other mechanical circulatory support. But importantly, 60% of these patients received no support at all in this database. Results showed use of Impella was associated with significantly higher hospital mortality and major bleeding compared to intra-aortic balloon pump. They also noted that between 2015 and 2017, balloon pump use went down and the Impella utilization went up. There was another article published in Circulation which looked at comparative effectiveness and cost of Impella versus balloon pump. And they found that the hospitals with higher rate of Impella use had high adverse event and the cost. So clearly a concerning reports from this observational non-randomized data in a population that's very sick, very difficult to define, with a very upfront high mortality risk. Now, George, I use all of these devices quite frequently, and this is, making it very difficult to figure it out who should be having what. By looking at this data, would you advise me to change my current practice in any way?
No, I think the important thing to realize are a couple of things. Neither of these studies is perfect in terms of selecting patients. They tried to show that there was some reasonable equity of the patients, but it's really very poorly done, particularly in the Circulation paper. That clearly was an insurance database. It has both high-risk PCI as well as shock mixed in there. It seems quite certain. The other first paper that you mentioned, or first presentation, has not been published, so we really don't understand even how they collected the patient population. Recognize that the cath PCI database, until 2017, which means most of the time the study was taken, did not require an entry as to what kind of support device they got. And I think they worked backwards probably through the chest pain database to try to figure that out. But I think there are potentially a lot of holes there. The other thing to know, and I'm the old guy, okay, Raj, and I lived through the development of the intra-aortic balloon pump. And it was put in with a cut down, there were all kinds of bleeding complications and so forth. And the use was always in somebody who was next to dead. And I think that's the problem here too. We're first getting where we're understanding that earlier is better. But I think these studies are often corrupted by people either because of insurance issues or just inexperience, waiting to, it's hopeless, but let's try this. And that's not where you see your benefits. It's with doing it upfront early, making the plans early. And I wouldn't change anything.
Yeah. So, obviously there's been a lot of call about, doing randomized trials in cardiogenic shock. Obviously, it would be great to see one. But I bet you that, a shock randomized trial would be very, very difficult to enroll. The other thing that I find it very challenging.
It's been tried in the past, and it
has difficult enrollment, right?
Very difficult.
The other thing that I find very challenging is even if you have randomized data, patients, when they come in with the shock, they are in different stages of shock. So, I'll give you an example. I had a guy who came to the emergency room with arrest, big ST elevations. He had 45 minutes of CPR. He very likely had anoxic brain damage, but family insisted they wanted everything done. Now patient had rhythm and a blood pressure and a huge ST elevations. He intubated, heavily sedated on propofol. I fixed his LID and I put a mechanical circulatory support in, and his heart was okay. But what's going to be?
Did he wake up?
Yeah. See, that's the challenge. But this patient would count as whatever the support device that you put in a database like this. So I think that I find it challenging to interpret it because I don't know what type of patients were included in it. And it's going to be challenging. So, however, we should conclude by giving our clinician viewers some guidance about how to manage shock and what should be the most contemporary treatment pathway you should use. So
I
tell
do
us
think,
about that.
I do think all the data now, the really new data that's coming out, we know based on randomized trials, at least in shock, however it was defined, and your point about definition is important, did not change outcome. So I think using it in true shock, the Impella is a device that's easy for most people to put in most centers, and a lot of centers don't have ECMO. There are a lot of complications with ECMO, so it's a very reasonable device. Data from the National Cardiogenic Shock Initiative, which is a registry data, but it's being well kept, and Bill O'Neill is doing this, and that shows an improved survival based on getting the device in early, before PCI, and using right heart catheterization, and following these patients carefully.
Yeah, to be fair though, however, there is a difference between this study. This study included 43% of cardiac arrest resuscitated patients. Now, National Cardiogenic Shock Database didn't take all the arrest patients, correct?
They take successfully arrested patients that are not thought to have.
Probably not as sick.
May not be as sick. It's
Right.
hard to
Maybe
know.
may not as sick.
Hard to
but I
know.
think that's the important point, that this is what we need to learn.
If we're going to do it, we got to do it early, and we got to, I'm all for not using our resources on patients that are hopeless. I think the problem with cardiac arrest is we have to make decisions so often on the fly, and we don't know. But with cardiogenic shock, I think we have a better chance if we can, without arrest, we can assess frailty pretty easily, quickly, and make a decision.
Now, I just had an opportunity to talk to Dr. Thiel, who's been a principal investigator for Shock 2 trial, IABP Shock 2 trial. And I was asking him about the utilization of right heart cath in Germany. And he said it's very infrequently utilized. And now, obviously, Dr. O'Neill in National Cardiogenic Shock Database and other experts in U.S. now saying, okay, we should really do right heart cath. So tell us, what numbers are you looking for on the right heart cath that's going to help the doctor to decide what we're going to do?
So I think there are a couple of important things. The right heart cath will clearly confirm a shock diagnosis if there's a question about it. Two, it will give you information about cardiac power output because it tells you how well you're perfusing the periphery. And more than just the blood pressure, which is what it's easy to pump up a cuff and get a blood pressure. We really want to know how the patient's doing with peripheral perfusion. And the cardiac power is an important predictor. So it gives you that. In the patients who get left ventricular support, let's say, some of them don't get better. And then the question is, what's the problem? And in many of them, it's because the right heart is failing. And the right heart cath gives you the information as to whether it's a filling problem with the right heart or whether it's really just a diseased right heart that's not functioning and you want to put in
additional support.
So you got to have those pieces of information. And it's interesting because the people that did the study inpatient that looked at use of right heart cath and heart failure didn't show a benefit. They have now gone back and looked at the national data for use of right heart caths in shock, which shows a benefit in outcome. And they've said that in shock, it would appear that a right heart catheterization really does make a difference in terms of outcome. So I think we're getting information to support that.
So we used to be like a German practice, and we used to not do right heart cath all the time, but now we are doing universally right heart cath in all of these type of patients that we think are having a shock, and we are leaving the swan in for further management, regardless of whether they had a balloon pump, Impella, or ECMO.
But the point I would make about that too is I think that's important, and I agree wholeheartedly, but I think one of our crimes in the past with the right heart was we left it in far too long. So I think we need to ask ourselves, how long do I really need it in this patient to get important information?
Usually 24, 48 hours?
Something like that.
Yeah,
if the patient is doing well, then you can get it out.
So George, it has been a great year in advancing our ability to make informed clinical decisions based on science. However, after reviewing all of these scientific reports, it is clear that individualized patient care is still of paramount importance. 16 years ago, when I wrote the first preface for C3, I said, that our specialty is as much an art as it is a science, and is still true today. I hope you all enjoyed our discussion today. We would love to hear back from you with any questions and comments. I also like to invite you to join us at C3 2020 in Orlando, Florida this June. This year's program will be most exciting that we have ever prepared, and it will be a show not to miss. So thank you, George. Great to have you here. It's been a wonderful discussion.
Thank you for having me. I think the year 2019 will be seen as a great year for science, and that's always great news for our patients. But I agree, we still have to make individual decisions.
Yeah, so I think that everybody have a wonderful 2020. Happy New Year, and I look forward to seeing you in Orlando this June.